In this lecture, we will talk about the structure of the spinal cord. These are the objectives that you have to know once you finish this lecture as well as the practical. Now, as you know, the spinal cord is the continuation of the medulla oblongata, starting from the cerebrum and then coming down as a cord, right? So generally we call the spinal cord as a part of the central nervous system. So the brain and the spinal cord are the main parts of the central nervous system. So the spinal cord continues down from the medulla, that is the last part of the brain stem, and then it passes out of the cranial cavity through the foramen magnum. Okay, and then it runs down inside the vertebral canal, which is formed by the adjacent vertebral foramina. Okay, so you have seen a skeleton of the vertebral column, and you see that all the vertebral foramina are lined up, creating a tunnel, and through that tunnel you get the spinal cord traveling. Now in this diagram here you can see that clearly. Now posteriorly you get the vertebral spines and the vertebral arches and the vertebral foramina which form the tunnel, and the spinal cord is running through it, right? Anteriorly you will get the vertebral bodies and the intervertebral discs, right? So that is the spinal cord, and it is lying inside the vertebral foramen, and all the foramen together will form the tunnel. Okay, so this will protect the vertebral column from any harm because of the skeleton, right? That the hard bone forms the vertebral body as well as the vertebral spines and the vertebral arch. And also you have lots of ligaments surrounding the vertebral column, which helps to create this tunnel, which becomes more of a fibroosseous tunnel, right? So if you look at the spaces between the vertebrae, you see that there are a little bit of spaces, and all these spaces you get different ligaments, right? So the ligamentum flavium, which is really important, posterior ligament, right? Posterior longitudinal ligament, and the anterior one of course is beyond the vertebral bodies, right, towards the body side. Okay, so posterior longitudinal ligament and the ligamentum flavium forms this fibroosseous tunnel for the vertebral spinal cord to travel in. Okay, right? So here in this MRI, you can see very clearly the spinal cord traveling in the vertebral canal, right? So this is the cross section of the spinal cord. Here you can see cross sections of the vertebral bodies and the discs in the middle, and here you can see the vertebral arches and the vertebral spines. Okay, so overlying that you can see these black areas which are the ligaments. Okay, so the spinal cord is protected inside the vertebral canal. Okay, so these arrows show you the spinal cord. Okay, and these are the two parts of the vertebral column which has been because of the MRI where how the picture has been taken. Okay, and these are of course the posterior wall muscles. Okay, and here also another picture which shows you the spinal cord going through the vertebral canal. Right, so if you take the spinal cord and look at its gross structure, you see that it is a cylindrical structure, right? It is basically like a cylinder. However, it is flattened slightly front to back. Okay, so if you look at this, the anterior surface, you see that there is a deep groove which we call the anterior median fissure. Okay, anterior median fissure. And posteriorly, if you look, there is a shallow groove which is called the posterior median sulcus, right? So the anterior groove is very deep, the posterior groove is shallow. Thereby, if you look at a section of a spinal cord, you can figure out which side is anterior and which side is posterior. Okay, right. So the spinal cord is thickest as it leaves the medulla, but then later it goes and tapers off as it comes towards the end, right? And at the lower border of L1, it ends as the cornus medullaris. Okay, and then the lower spinal nerves, which arise from the cornus medullaris, extend down as the cauda equina. Right, so we'll see pictures and then you can understand better. Right, so this is the spinal cord as it comes down the vertebral canal, and this is the place where it ends, that is called, it is triangular, so it's called the cornus medullaris. And the spinal nerves after L1 vertebral level just hang down like this, move down like this, and it's said to look like the tail of a horse, right? So that is why it's called cauda equina. Okay, tail of a horse, right? Okay, so here is a dissected specimen of that. You can see the cauda equina going down like this, and the cornus medullaris where the spinal cord ends, and what we call the filum terminale, which is actually the extension of the pia mater, right? Going down like a small line, like a small filament, and attaching to the tip of the coccyx. Okay, right. So as you probably know, in the developing embryo, the spinal cord actually extends all the way down to the sacral region, right? However, the vertebral column grows faster than the spinal cord during fetal development and during childhood, right? So therefore, the spinal cord ends at uh, L3 level at birth, okay, L3 level at birth, and as the child grows up, as he becomes an adult, the spinal cord will end at L1 level. Okay, so always remember that in a child, the vertebral column, the spinal cord extends much lower than in an adult. Okay, so if you try to do a lumbar puncture in a baby, you have to remember that the spinal cord doesn't end at L1, it extends up to L3, right? So that you have to do the lumbar puncture below L3 level in babies. Okay, right? So what is this lumbar puncture? It is the introduction of a needle into the subarachnoid space in order to withdraw cerebrospinal fluids, right? So I hope you know the spaces and you know that these spaces extend down into the spinal cord as well. So if you want to withdraw some cerebrospinal fluid, one thing that you can do is a lumbar puncture, right? So that is the easiest way of getting it and examining it, right? So if you have some sort of infection or some disease in the uh, central nervous system in the brain, then you might have to withdraw some cerebrospinal fluid and examine it, right? So the easiest way to do it is to do a lumbar puncture. All right, so in an adult, the spinal cord ends at L1. So when you're doing this, you're entering the subarachnoid space, which extends into the vertebral column. You have to be careful not to injure the ends of the spinal cord, right? So if it is an adult, you can actually do it at L3, L4 vertebral level. That will prevent the damage because the spinal cord ends at L1. All right, and also into the subarachnoid space, you can give anesthetic drugs, right, or contrast media that can be introduced so that you can either do investigations or you can do a surgery without actually giving general anesthesia. You can give an anesthetic drug to the subarachnoid space so that the person won't feel pain and do surgeries. Okay, so here you can see where the spinal needle is inserted. Okay, so those are between the two vertebral spines. You go in and introduce a needle at about L3, L4 level, right? So this is the position of the patient, and you slowly put the needle in and take out some fluid. All right. So here in the subarachnoid space, you have the CSF flowing, right? And if it is a baby, then you have to always remember that the spinal cord goes below, right? So you have to go below L3 level if you're going to do a lumbar puncture, okay? And babies, of course, have very shallow vertebral um, canals, so you have to be very careful. It is a very delicate process, okay? So then, just about the different meningeal coverings of the spinal cord. As you know, it extends from the foramen magnum, right, and extends up to um, uh, down into the whole of the vertebral canal, right? So you have the meningeal coverings going down with the spinal cord, and the dura mater, which is extending down from the margins of the foramen magnum, goes down up to S3 level, sacral, third sacral vertebral level, right? So because of that, the epidural space, right, epidural space, which lies superficial to the dura mater, will continue up to S3 level, all right? And this epidural space will contain the internal vertebral plexus, right, some sort of fat tissue, and also the spinal roots, all right, spinal roots. And the dura mater will actually reflect onto the spinal root and merge with the epineurium of the exiting spinal nerves, okay? So dura mater extends way down, right? And then considering the arachnoid mater, it continues from the brain and then extends down up to S2 level, right? So that means it stops a little before the dura mater, all right? And therefore, the subarachnoid space, which is found between the arachnoid space and the pia mater, right, uh, continues from the brain, from the cranial cavity down around the spinal cord, right? And the subarachnoid space, therefore, will continue up to S2 level, okay? Now, as you know, the pia mater is very closely adherent to the brain substance. Similarly, it is very closely adherent to the spinal cord, and it goes down um, all the way until the spinal cord finishes, right? And also it forms what are called the denticulate ligaments, which attach the spinal cord to the vertebral column laterally, all right? And then finally the pyramid actually forms what is called the filum terminale. I showed you that picture before, and that pierces the dura mater and goes down furthest and attaches to the coccyx, okay? So the meningeal covering that goes furthest is actually the pia mater, which forms the filum terminale and attaches to the coccyx, right? All right. So the dura mater extends up to the S3 level and the arachnoid mater up to S2 level. Okay. So this is clinically very important because you have to remember to what extent the epidural space and to what extent the subarachnoid space is there within the vertebral column, because you use this for giving anesthesia or performing lumbar puncture in patients. Okay, so that the same thing I just told you, all of it, I have shown you in this diagram. Now this is inside the uterine cavity, intrauterine life. The spinal cord is shown in yellow. It extends downwards with the pia mater. Okay, and then this is the coccyx. And then at birth, this has actually, the bones have grown so fast that the spinal cord hasn't grown that much, nor have uh, the meninges extended. So at birth, you have the spinal cord at L3 level, okay, and this is about S2 and S3 levels. All right, so the subarachnoid space up to there, all this space. So below L3, you have the subarachnoid space, and here the epidural space extends up to about S3. All right, and this is the same in adults, S3 and S2, but the spinal cord is at L1 level. All right. And then you can see the filum terminale extending down onto the coccyx in all three stages. All right. So remember this, that the spinal cord grows slower than the vertebral column. Because of that, the meningeal layers finish as different levels, and the spinal cord ends at different levels at different stages of development. Okay. Right, so if you look at a cross section of a spinal cord, you can see this. I told you about the posterior median sulcus and the anterior median fissure. Okay, and then you have the spinal nerves leaving the substance of the spinal cord, and then you get the dura surrounding it. Okay, so this is the dura and it is extending on to the spinal nerves, right? And you can see blood vessels also traveling on the surface. Okay, so here you have the central canal, right? And surrounding the central canal, you have the substance of the spinal cord. And the red shows you the pia mater, which is closely adherent to the substance of the spinal cord. Then, yeah, so that is the pia mater. And then surrounding that, you have another layer, meningeal layer, which is the arachnoid mater, right? Arachnoid mater. So between the pia mater and the arachnoid mater, you have the subarachnoid space, all right? Okay, so then surrounding that, you have the dura mater, okay? And surrounding the dura mater, you have the vertebral canal, right? Or the spinal canal, which is made out of bone, okay? So where are the spaces? That is the subarachnoid space between the pia mater and the arachnoid mater. And this is the epidural space, which is between the dura mater and the bones of the bones and the ligaments of the spinal canal. Okay, so here again another picture to show you that. So this becomes the epidural space. Most of the time there is fat there. Okay, and inside that you have the dura mater layer here, and adherent to that is the subarachnoid space below that. So this is the arachnoid mater and the pia mater, which is closely adherent. So that is the in blue you see the subarachnoid space, in yellow the epidural space. Okay. And then, as I said, we can use it for anesthesia. So epidural anesthesia is given into the epidural space, and that causes loss of pain sensation in the perineal and pelvic region. Okay, so the spinal nerves which are coming down in the chorda equina can be anesthetized by introducing anesthetic drug into the epidural space. Okay, so this can be used in pelvic surgeries, perineal surgeries, and also during labor or during cesarean section. Okay, so epidural thing is because you can put what is called epidural catheter into this space, so that you can introduce small dosages of the anesthetic, so that the person will be free of pain even after surgery. Okay, so this can be used during labor. You can introduce the small catheter and give small doses of the drug as long as labor lasts. Okay, and so you give that to the epidural space. You give spinal anesthesia, what is called spinal anesthesia, into the subarachnoid space. All right, so when you give that, it goes in the subarachnoid space, and depending on the volume that you give, you can get a level of anesthesia. Okay, so the lower lumbar and the sacral nerves will be anesthetized, and similar to epidural, you can perform surgeries below that level, right? However, spinal anesthesia, at that point you give the drug and withdraw the needle, right? And that will last, few hours, and the patient will be completely anesthetized below that point. Okay, so this again can be used for different surgeries of the pelvis and perineal areas. Okay, so here again you can see a, a MRI scan, but this is not a normal scan, right? So if you look carefully, you can see that there's a defect here. All right, so this is a vertebral body, right? Vertebral body, and you can see a bulging thing coming there. So either this is a secondary deposit or a tuberculous abscess, whatever it is. This is impinging or compressing the spinal cord. Okay, so here this causes damage to the spinal cord at this particular level. Here also you can see there's the disc. Actually, this is a disc prolapse. So the disc is going and impinging or pressing on the spinal cord. Okay, so here actually, because this is lower down, this will be pressing on the cauda equina area. So the spinal nerves which are running from here can get damaged, right? So initially, if it is slow growing, the patient will have all sorts of symptoms of these involved spinal nerves, and then if it goes through, there may be permanent damage, right? Okay, so then you know that in the spinal cord you have all these segments, right? You have the cervical, thoracic, lumbar and sacral segments, and from these segments you get the spinal nerves arising, right? So you have 31 spinal segments, one C1 to C8 in the cervical region, T1 to T12 in the thoracic region, and L1 to L5 in the lumbar region, and S1 to S5 in the sacral region. So that is why when we talk about dermatomes, we talk about the same spinal segments, right? So the spinal cord, through that you get the spinal nerves arising, right? So you have different numbers of spinal nerves: 8 cervical, 12 thoracic, 5 lumbar, and 5 sacral, and 1 coccygeal nerve. Okay, and then if you look again at the gross appearance of the spinal cord, you see that there are two fusiform enlargements. That is at the cervical region where you have the brachial plexus arising, right? And in the lumbosacral region where you have the lumbar plexus for the lower limbs arising, right? So C5 to T1 nerve roots will give rise to the brachial plexus, and because of that, that area in the spinal cord is larger. Okay, so similarly, the lumbar plexus, which comes from the lumbosacral region, will have this area enlarged because of that. Okay, right? So during growth, as I said, the vertebral column grows faster than the spinal cord. Therefore, the spinal levels and the vertebral levels do not coincide. Okay, so that the 10th thoracic segment, right, of the spinal cord is found at the T7 vertebral level. Okay, that is because the spinal cord is shorter than the vertebral column. Okay, right? So if you really look at the different ones, what they say is cervical vertebral level, add 1 to find the spinal segment. Thoracic vertebral level, add 2. Lower thoracic, add 3. Like that, you can find the spinal segment by this method. Right? So why do we need to know this? Because in a situation like this, now this is a x-ray of a person with a road traffic accident, right? So this man has had a fall, road traffic accident, and his spine has broken here, right? So you can see that the T12 thoracic vertebra is dislocated here, right? So the spinal cord segment which is related to this area becomes very important. So what is the segment that is there at this level? Because the spinal cord is shorter, you will have a lower level here. You won't have the T12 level here. You have a lower level here, right? So this person will show symptoms of that level getting damaged, right? So this is the reason why we need to know what are the spinal segments which are related to the T12 vertebral vertebra. Okay, right? So if we talk about spinal nerves, each spinal segment gives rise to two spinal nerves on either side, and the spinal nerves, as you know, arise from two roots. Okay, so you learned this earlier as well. So you have the anterior ventral root, which is motor, the posterior dorsal root, which is a sensory root, which has its dorsal root or posterior root ganglia. Okay. Then the posterior root forms the ganglion within the intervertebral foramina. Okay. And then within the foramina itself, the two roots will unite to form a mixed nerve, right? Mixed spinal nerve, and then only it will exit the vertebral column. Okay, so here are the vertebral canal and the spinal nerve coming through the vertebral canal here, right, between the vertebrae. Okay, so this is a gross specimen of it. Now you can see this is the posterior median sulcus, and you can see these small ones actually, because the spinal segment is a little bit long, the, the nerves come out in rootlets. Okay, tiny rootlets, and uh, also you can see those rootlets coming from each of the segments, and this is called the denticulate ligament, as I told you, formed by the pia mater, and then outside you have the dura mater, and lining the inner surface of the dura mater you have the arachnoid mater. Okay, so this is the fourth ventricle up here, and from the medulla it is coming down. So this here is the foramen magnum area. Okay, and also you can see the vertebral artery going up, so that makes this the uh, first cervical vertebra. Okay, right, so as I said, each root arises from several rootlets. Okay, and the rootlets come together and only form the dorsal and ventral roots. All right, so here you can see, so if this part is the spinal segment, it is a bit thick. All right, so one nerve can't arise, so you get small rootlets, and they come together and form the ventral root. Right, on anterior side it forms the ventral root, and posterior side it forms the dorsal root. Right, so all this happens just outside the vertebral canal here, just outside the vertebral foramen, and then only the spinal nerve will exit. Right, of course on either side you get the sympathetic trunks. Right, so this also shows you that, so the different meningeal coverings and the rootlets and how they form the two dorsal and ventral roots. Right, so functionally just saying one is okay, but anatomically if you look at it you can see these rootlets very clearly. Okay, so if you look at a gross dissection you'll be able to see that. All right, so you know the structure of the mixed spinal nerve. I hope you remember this. So you have the dorsal root ganglion, and this mixed spinal nerve, ventral root coming like this. So whatever uh, these will be motor and sensory, right? So the anterior root or the ventral root will be taking messages down, motor, okay, and the sensory one will be bringing information into the spinal cord, right? So into the central nervous system. Okay, and then of course they divide into anterior and posterior ramus, that you must have learned, you learned when you were talking about plexus formation. Okay, right, so as I said, the vertebral levels and spinal levels do not correspond. However, the spinal nerves leave the vertebral column at their corresponding vertebral levels. Right? So this is slightly different for what I said yes before. Now, when you have a spinal segment, you say this segment here. Okay, we'll do this. So here, this is the T12 spinal segment, and this is the nerve which now comes out of that T12 spinal segment, and it will travel down in the vertebral canal, and it will come to its specific vertebral body, and then only it will exit the vertebral canal, right? So because of that you have the exiting wheels different, right? So you the T12 spinal segment will have a spinal nerve exiting at its appropriate vertebra. Okay, right, so it will travel for some distance within the spinal canal, vertebral canal, before exiting. All right. Okay, so that's why I've said therefore spinal nerves travel downwards in the vertebral canal until they reach their corresponding vertebrae. Okay, right. So then the spinal nerves, just after leaving the columns, divide into anterior and posterior, as I told you. Anterior rami give rise to nerve plexuses that innervates the upper and lower limbs, and the posterior ones supply the back muscles and the skin. Okay, so you remember this, how these plexus are formed. Plexus means a meshwork, right? So different spinal nerves, we call them roots. They join together and then form different um, nerves, right? So because of this, different spinal segments can supply different muscles and supply a large number of muscles, right? Because they form a meshwork. Okay, so we learned about the brachial plexus. You will be learning about the cervical plexus in this module, and you learn about the lumbosacral plexus as well. All right, so now this is actually a cross section of the spinal cord. It's a section to show you the different parts. Now you can see the posterior median sulcus, anterior median fissure, okay, central canal, and you can see the gray and white matter, right? So similar to the central nervous system, the spinal cord also has the gray and white matter. However, the gray matter is inside and the white matter is outside. Okay, so gray matter forms the cell bodies and the white matter forms the nerve tracks. All right, peripheral white matter forms the nerve tracks and the gray matter forms the cell bodies. All right, so if you look at the gray matter, it is arranged in H-shape uh, arrangement, right? So if you look at the posterior aspect, you have what is called the posterior gray column. Anteriorly, you have the anterior gray column, and joining those two, you have the gray commissure. Okay, gray commissure. And in some areas of the spinal cord, like the thoracic, right, you have what is called the lateral gray column, extra cell bodies. Okay, all right. And then the amount of gray matter in a particular region of the spinal cord actually is proportional to the number of muscles innervated by that region, right? So you saw the fusiform appearance also, where it is larger because of the more number of cells and fibers. Okay, so most of the gray matter is seen in the cervical and lumbosacral segments where the innervation for the limbs are, right? So that area you will have more gray matter, right? So the shape of the spinal cord actually, again because of the fusiform arrangements and all that, will differ according to this place where you're taking the cross section, right? So the cervical will be large, it will be oval shaped and slightly flattened, right, with lots of uh, gray matter. And thoracic area will have less gray matter because after the T1, only the small amount of intercostal muscles and skin is being supplied there, right? So you have less gray matter in the thoracic area. Again, lumbar area, you will have lots of gray matter because of it's supplying the lower limbs, right? And then in the sacral area, you have less white matter because all the ascending tracks are less, ascending and descending tracks are less as you come downwards, right? Otherwise, of course, the white matter is large in the upper ones. Okay, so my white matter is less in the sacral region. Okay, so greatest matter of gray matter is found in the cervical and lumbosacral enlargements because they innervate the limbs. Thoracic and upper lumbar have small amounts of gray matter because they innervate the thorax and the abdominal regions. Absolute number of nerve fibers in the white matter increases at each successive higher spinal segment, right? So the lowest will be at the sacral, highest white matter content will be at the cervical because all these fibers are going up or coming down, right? So if you don't have many, as you come down into the body, you don't have many white mm, spinal tracks coming down, right? And the lateral horn is present from T1 to L2 levels, right? Lateral horn. Then posterior horn at the cervical level is narrower than in the lumbar and the anterior horn is broad in both, right? So these are different features of the different areas of the spinal cord. You don't have to know details, but when you look at a cross section of a spinal cord, you have to be able to guess at least what place it may be by these different characteristics. Okay, so this diagram, I think you have to remember this all the time, because the next thing we are going to do is the nerve tracks, right? Ascending and descending tracks, which are very important for you in order to diagnose different lesions of the spinal cord, right? So this diagram you have to be able to draw and remember this carefully, okay? So you have the central canal and you have the gray matter in the posterior horn, the anterior horn, if there is lateral horns, right? And then the white matter, you divide it into the posterior white column here, right? So the posterior white column is the white matter between the two posterior horns, okay? And then on the lateral side, on either side, the white matter between the posterior column and the anterior column is what we call the lateral white column, okay? Lateral white column. And then the thin strip between the two anterior horns are called the anterior white column, okay? So posterior white column, lateral white column, and anterior white column, okay? So these are the areas of the gray matter and white matter, and where all the spinal tracts are arranged, right? So remember this picture so that it will be easier for you to learn the nerve tracks, okay? Right, so then talking a little bit about the anterior gray column, what are the things that are there in the anterior gray column? Okay, so you find cell bodies of multipolar alpha efferent or motor neurons that innervate skeletal muscles, right? In the anterior gray column, that those are the cells that you find, right? And also you will find multipolar gamma efferent neurons, which are from the neuromuscular spindle, okay? And axons from these will pass in the anterior spinal root and go into each of the muscles, okay? Right, so if you look closely at the posterior gray column, so that is the anterior one, then the posterior gray column, you will see that there are four nerve cell groups, okay? So one is called the substantia gelatinosa, which has Golgi type 2 neurons. They receive afferents from pain, temperature, and touch, okay? Pain, temperature, and touch travel together, okay? And then the other nerve cell group is the nucleus proprius, which is neurons which receive inputs from proprioception. That is why it's called nucleus proprius. And this 2-point discrimination and vibration. All right. So you will learn further about this, and also in physiology you will learn. But proprioception actually means joint position sense. That is, even if you are not looking at your joints, you know exactly where they are. You know if your knee is bent, right? If your toe is bent or straight, right? So if you close your eyes and ask somebody to hold your toe and move it this way and that way, you know exactly where, how your toe is bent, at what angle, and all that information is there, okay, even though you're not looking. So that is the information we call proprioception. Then 2-point discrimination is actually being able to identify two sensations as two, right? And not as one. Okay, so this depends on the distance between each of the sensory receptors. Okay, so if you know about your body, you know that the fingertips, right, are very sensitive, much more sensitive than the dorsum of your hand. All right, and also the back, your back is much less sensitive than the dorsum of your hand or your fingertips, right? Your face is more sensitive. Like that, different parts of the body are more sensitive than the others. Okay, so to check 2-point discrimination, you can actually take two pins, hold them very close together, and slowly touch your skin in different areas, right? So in very sensitive areas, you can feel the two pin points pricking separately, right? But if you do it in the back area, or area where there is less sensation, you cannot discriminate it as 2 points, two pricks. You will discriminate it as one. Okay, Then the other one is vibration sensation. That is, if you take a tuning fork, right, and hit it on something and keep the fork on a bony point, then the person will feel the vibration. Okay, not the touch but the vibration. So these sensors actually travel together, and their cell bodies are found in the posterior gray column in what we call the nucleus proprius. Okay, and then you get nucleus dorsalis again for proprioception. All right, and then visceral afferent nuclei coming from T1 and L3. Right, so these are the nerve cell groups that you see in the posterior gray column. All right, so here is the posterior gray column. This area is called the substantia gelatinosa. This area is the nucleus proprius. Okay, so they have cell bodies for pain, temperature, touch, and joint position sense, vibration, and discriminative sense. Okay, right. So then, when if you look at the lateral gray columns, it has small cells that give rise to sympathetic and parasympathetic fibers. Right. So preganglionic sympathetic fibers, which are given off from T1 to L3 spinal segments, which we call the thoracolumbar outflow, right? And preganglionic parasympathetic fibers, which are given off from S2 and S4, which we call the sacral outflow. All right. So you have learned about the autonomic nervous system earlier. Just go through that. You will have lectures in physiology also, right? So thoracolumbar and sacral outflows will have lateral gray column for sympathetic and parasympathetic cell bodies. Okay, then of course you have the gray commissure and the central canal. So gray commissure is the connecting areas. You have anterior and posterior gray commissures, which are closely in relationship to the central canal, right? And the central canal continues from the fourth ventricle and ends at the filum terminale level. Okay, and the central canal is lined by what we call the epithelium of the uh, nervous system, the ependymal cells, right? So you learn the histology of this, so you know what ependymal lining is. Okay, so then looking at the white matter, actually this is a little complex because we will learn this more and more as we do the nerve tracks, right? So the nerve tracks will be the white matter generally, what we'll be talking about for that lecture. So if you look at the posterior white column, right, posterior white column, you have two places called, one called the fasciculus gracilis and the other one called the fasciculus cuneatus. Okay, these are the areas that are mentioned. So grossly also you can make out these areas. Then in the lateral column, in the lateral white column, you will have the spinothalamic tracts and the spinocerebellar tracts, right? That means from the spine going up to the thalamus, from the spine going up to the cerebellum, okay? And then the anterior white column will have again some spinothalamic fibers and vestibulospinal tracts, right? So this is like, I mean, the names are explanatory on what are these fibers which are traveling between two regions. Okay, so the tracks in the white matter becomes very important because that helps you to diagnose different spinal cord lesions. Okay, so please go through this and get ready for the nerve tract lecture, which you have to understand properly to be able to answer the questions, right? Okay, so I want to show you this and end the lecture. So this is basically an MRI of a patient who's involved in a head-on collision, right? So this is the brain here, and you can see the spinal cord here. This is the neck, right? So the neck has been forcefully extended, thrown back, right? So because of this forceful extension, the the vertebral column has fractured, the cervical spine has fractured, causing impingement on the spinal cord, right? So this high up lesion, if this is completely transected, then all the nerve fibers going below this will be completely lost, right? So that means this person will be paralyzed from neck downwards, which is a huge problem, which the most probably will end up, the patient will end up dead because the diaphragm will be paralyzed and the patient won't be able to breathe. Okay, so unless the patient is taken to hospital and it's corrected and the spinal cord can be recovered, the patient will die, right? So this is the reason why somebody goes through a accident, you're not supposed to bend them, right? I mean, if you have seen people being taken to hospital inside three-wheelers and vehicles, they sort of, bend them in all directions and put them inside a vehicle and take them, right? But if you do that, you yourself, while trying to save the person, might actually cause injury to the spinal cord. Okay, so any accident, if person is involved, you have to be very careful not to bend the neck. All right, so whatever possibilities there is, you have to carefully lift the person while supporting the head so that the neck doesn't extend or flex, right? More than flexion, actually extension, both, I mean flexion and extension both can cause broken parts of the vertebral column to completely pierce into the spinal cord, right? So this kind of thing is very important, and this has to be told to people, right? So that when they are trying to save someone's life by bringing them to the hospital, they will understand this. Okay, so this is what a normal one should look like. The previous one, you saw how it has the abnormality there. Okay, so this is the normal spinal cord MRI. So that is all we have. Then next lecture the uh, will be the nerve tracks. Okay.